the Duke Center on Addiction and Behavior Change. I'm Ed Levin, director of the center as a part of DIBS, and thanks to Tyler Lee for coordinating the logistics here. And we're getting towards the end of the seminars series for the spring of 2021. So just wanted to tell you about what's coming up. First of all, on the 28th of this month, in 2 weeks, we'll have the last talk by Isaac Lipkis, a faculty member in the nursing school, on perceived risks of water pipe tobacco smoking among young adults. And then we're all going to be busy in the lab and clinic over the summer, I'm sure, and maybe take some vacation. But we'll reconvene in the fall, starting August 25th, with Ray Lee from Yale University, talking to us about chronic cocaine craving and looking at cue effects and imaging. And then we're going to go on. We have a pretty full schedule of people locally and also around the country, including several talks kind of continuing on this nicotine research conference, which had been going on for 25 years. Jed Rose and I had put together, but now it's going to be a nicotine research seminar series. So in the middle of the CABC seminar series, we'll have the nicotine research seminar series. So it's up on the schedule here. It'll be listed on the website. And also I just had to let people know there's a new Zoom room address. So it's on the schedule at the top, and the link will be sent out on a weekly basis as we go through the seminars. So, and anybody who's missed this seminar, they are archived on a YouTube channel, which is, the address is listed on our page on the CABC page and the DIBS. So now I'd like to introduce today's speaker, our own Nicole Schramm-Sapyta, who is Associate Professor of the Practice and Duke Institute for Brain Sciences and Associate Director of DIBS. And Nicole earned her PhD at Vanderbilt University in 2000 and came to Duke in 2004, and has been really a key player in brain sciences here since, including addiction. And she's going to be giving a talk today about examining the relationship between mental health services and law enforcement in Durham County. Nicole?
All right, thank you, Ed, for that introduction, a little walk down memory lane, which makes me really want to thank some of the people on this call, especially Ed and Cindy Kuhn and Scott Swartzwelder, who have known me since my days of giving cocaine and alcohol to rats, and feel like this is my first time sharing new data from the new direction that I went off in about 11, 12 years ago. So thank you guys for always supporting me through all these phases of my life. And I'm happy to see a lot of new friends today on the call as well. So I'm going to share screen if it will let me. So as Ed said, the title of my talk is Mental Health in the Justice System in Durham County. And this is work that's been done over many years. It's been growing over the past 5-6 years. At this point, it's a collaboration between the Durham County Detention Facility, or you'll see DCDF throughout the talk as the abbreviation, the Sheriff's Office, therefore, the Criminal Justice Resource Center, the Stepping Up Initiative, the Durham Crisis Intervention Team. So I want to thank all of those community partners. And then the actual work of all this data analysis has been done by our Data Plus and Bass Connections student teams here at Duke over the past few years. So the big questions that we've been asking is, how does the justice-involved population in Durham interact with Duke Health? And particularly, how does mental health relate to rearrest in this population? And are there ways that the Duke and Durham County can better collaborate? So I want to go through a little bit of a historical timeline about all the things that Durham has done. One of the things that I learned pretty quickly in getting involved with Durham County and all these different community groups was that Durham has really been trying hard to make things better for the most vulnerable members of our community. This is a little bit of a timeline, but you can see that in 2006, a substance abuse counselor was hired at the Durham County Detention Facility. There's been a mental health professional on staff ever since. In 2000, the crisis intervention team started, and I'll give you a little bit of history of what the crisis intervention team is. It's a partnership between law enforcement, first responders, and mental health services. And in Durham, that takes the form of collaborating with Alliance Behavioral Health, which finances the Durham Recovery Response Center. And the whole idea of a crisis intervention team is that when a police officer or a sheriff's officer, any first responder really, it can be EMS, can be fire, but when they see someone out in the community who is obviously suffering from a mental health crisis, rather than taking that person to jail just to get them off the street, they have the option of taking them to a mental health crisis center. The idea is that we don't want people cycling through the jail. We want them to get the help that they need. We don't want them arrested for silly things. We want them to get the help that they need. One of the negative events in the timeline was that in 2009, Dorothy, a Dix hospital closed. And we all know this was part of the deinstitutionalization process that was happening over many years. And Dorothy Dix was just the last hospital in North Carolina, the last mental institution to close in North Carolina. But what that did was that most people who were mentally ill and had nowhere else to go instead moved into our jails. And that certainly has been the case in Durham County. In 2012, a jail discharge planner was hired. In 2013, Alliance Behavioral Health hired a CIT coordinator and took the lead in planning and implementation. So between 2007 and 2013, the crisis intervention team was there, but Alliance really took a more active role in it in 2013. Between 2013 and 2017, 100% of Durham Police Department officers have now gotten mental health first aid training, which is an 8-hour training just to recognize, oh, that person's having a mental health crisis. 50% of the whole police force now, about 50% are now fully trained in the crisis intervention team model, which is a 40-hour training. So Durham has got a really good group and really good awareness of mental health issues that happen out in the community. In 2015, the Durham Stepping Up initiative was started, and I'll explain that a little bit more as well. Stepping Up is an initiative, it's a countywide collaboration that works across all the intercepts in the criminal justice system. So you've got law enforcement officers on the front line, you've got things in the jail that can happen while someone's incarcerated. We have a mental health court. We have mental health awareness and counseling in the probation system. So at every point in which someone could interact with the criminal justice system, Durham County's done what it can do. It's done as much as it can do to help those who have mental illness who are also justice involved. And then in 2018, 2019, speaking of the activities in the jail, a mental health pod in the Durham County Detention Facility was opened. A mental health court came online. In 2019, after the election of Santana DeBerry, the end of cash bail for minor offenses happened. And then in 2020, we started medication-assisted treatment in the Durham County Detention Facility. So all these good things were going on. And then, of course, life happened and we had a pandemic. So that will be, that's affecting all of our lives and certainly the detention facility as well. The data that I'm going to talk about in our analysis that I'm showing you today is from 2014 to 2018. So that was around this time the Stepping Up initiative was starting. A lot of good things were beginning to come online in the detention facility and mental health court. So we're kind of, the work that I'll show you is a little bit of a baseline that we'll eventually assess later to say how are all these things working. As I said, the study population is from 2014 to 2018. We got data on everyone who was incarcerated, all bookings into the Durham County Detention Facility. And an interesting period of this whole phase was that between January 2014 and June of 2015, the jail was applying what they called a mental health tag whenever personnel at the facility recognized that someone had a serious mental illness or a serious and persistent mental illness. And specifically, what generally falls into that category is schizophrenia, bipolar disorder, or major depressive disorder. So when the jail, and generally when those in the criminal justice field recognize serious mental illness, they're talking about illnesses that impair someone's ability to function in the criminal justice situation, in the criminal justice context. So they're not able to follow orders from the guards. They're severely acting out, things that are pretty serious falls into this category that received the mental health tag. Also, under that umbrella is people who need their medications while they are incarcerated in order to function. So here's a little more detail on our study population. There were 23,608 unique individuals incarcerated in Durham County between 2014 and 2018. 17,588 of them had ever been seen at the Duke Health System, and 14,672 of them were seen during that period, that 5-year period. Focusing in on that tagging period, 2014 to 2015, 6,631 people were seen at Duke during that first 18-month tagging period, and 231 people had a serious mental illness tag that was applied during that tagging period. So these are the subsets of the population that I'll be talking about. As just a reminder, that mental health tagging period was at the beginning of our data range. All right, so what do the demographics look like of the people who were both arrested and seen at Duke Health? So Durham is a pretty typical town. We have the unfortunately typical racial bias. Our incarceration rate is 71% Black, 20% white, 8% other. Pretty small proportion of Latinx, predominantly male. So pretty typical arrest demographics. When we look at the incarceration statistics, in general, people are booked into the jail 2.5 times in that 5-year period. They spend about 12 days, they spend between 10 and 12 days in jail on average. But if you compare in these last 2 columns here, those with and without the mental health tag, those with a mental health tag tended to get booked more often, so almost 6 times compared to 3 times. They tended to stay longer, and their longest stay tended to be longer. So these observations are pretty typical across the criminal justice literature, that those with mental illness have a harder time and are incarcerated more once they get. And it doesn't mean that people with mental illness are more likely to be rearrested, but once they are in that cycle with the criminal justice system, they tend to get cycled back into the system so that they're more often rearrested, stay longer. One caveat that I want to make the point of is that during the mental health tagging period, these were illnesses that were recognized in the jail. So it could be possible that people who spent more time in the jail would get the tag because it was all self-report. It was things that were observed by the guards and by the mental health professionals at the jail. So it could be that because people stayed longer, they were more likely to get a tag, but it also could be that because people's illness was so severe, they were less likely to successfully engage in life and less likely to stay out of jail. So there probably both of those things are going on. So where are the points of intersection between the Durham County Detention Facility and the Duke Health System? Not surprisingly, it's overwhelmingly the emergency department. Over 80% of the full sample who had been arrested were also seen at the Duke Emergency Department, or if they came to Duke, 80% of them came to the emergency department. Over 96% of people who had a mental health tag and came to Duke came to the emergency department. We also saw some attendance at the Lincoln Community Clinic, which is the free clinic. 45% of those with a mental health tag also came to the Lincoln Community Clinic. Only about 26% of the general population came to Lincoln Community Center. So overwhelmingly, they're using the emergency department. And that led us to do sort of a familiar face analysis. And what really started this familiar face analysis is that we asked our students early on to just get familiar with the data and follow a few people through their whole trajectory across the data set that we had. And a couple of our students found just a few patients who had been seen in the Duke Emergency Department 50 times in 5 years, 70 times in 5 years. So that really made us want to dig into this, this question of, are there people who are just in crisis and just bouncing from the emergency department to the jail? And so Michelle Easter in our group did a really detailed analysis of this. One of the first things that she found is that, yes, those with multiple incarcerations are certainly overrepresented in the familiar faces group in the emergency department. And for the purposes of just having a clear delineation, Michelle defined a familiar face in the emergency department as those who were seen more than 20 times or 20 or more times in 5 years in the ED. So we're saying of this population that we have who were seen at Duke, how many of them were seen more than 20 times in the Duke ED? 26.5% of those who were seen more than 20 times in the ED were also incarcerated more than 5 times. That's 155 people. An additional 19% of those familiar faces in the ED were incarcerated 3 to 4 times, so that's 111 people. If you put all of the emergency department familiar faces from our incarcerated population, there's 585. So those 585 formerly incarcerated people who were also familiar faces in the ED accounted for over 21,000 visits to the ED, and 8,300 of those visits were uninsured. So the cost to the health system is over $11.7 million. The cost to the county for all of the bookings is over $3.5 million. So these are our most vulnerable citizens. These are the people who are cycling back and forth, constantly in crisis mode, going from the jail to the ED, and they're costing both the health system and the county a lot of money. And just the human cost of people being in crisis, that much is staggering. So when they come to the ED, why are they coming? And this is summary data, again, that Michelle generated, generally looking, so these numbers will not add up to 100 because these are people who are coming to the ED for different reasons. And so it's gonna add up to more than 100%. But about between 55 and 70% of the familiar faces at the ED are coming into the ED for digestive, urinary, infectious illnesses. So illnesses that probably shouldn't be seen in the ED, probably ought to go to a primary care physician, compared to the non-familiar faces who are only coming in with that problem 15 to 25% of the time. The next category, injuries and poisonings. These are things that probably should come to the ED. 90% of the familiar faces are coming in with what seems like a standard emergency reason. 45 to 60% of the non-familiar faces are coming in with those kinds of problems. Mental health issues, again, 80% of the familiar faces are coming in with mental health issues. Only about 25% of the non-familiar faces are coming in with that. And then chronic conditions, which again, probably should be better managed by outpatient care and preventive care. Chronic conditions such as cardiac, respiratory, endocrine, to diabetes care. About 50 to 65% of the familiar faces are coming in for these types of issues, and only 10 to 25% of our non-familiar faces. Pregnancy and childbirth is much smaller. So you see that the familiar faces are coming to the ED with a wide range of problems, some of which are true emergencies that probably do need to go to the ED, but a lot of which probably could be better managed by other clinics, by outpatient clinics. And I would be remiss in this audience if I didn't talk about the opioid problem and a little bit of drug addiction. So Liz, one of the students in our group, was curious about people coming to the emergency department for an opioid overdose. And we know that's a huge problem these days. I was actually surprised at the small number here. So we looked in the 12 weeks after their release, because we were curious about the idea that we all know, which is that immediately after release, shortly after release, is when someone is most likely to experience an opioid overdose because their tolerance is down, because they haven't had access to the opioid during their time in jail. So we looked at the first 12 weeks after release from incarceration. Only in this 5-year period, only 38 previously incarcerated people came to the emergency department, the Duke ED, with an opioid overdose. And that was concentrated in the first 2 weeks after release and continued to decline over the 3rd, 4th, 5th, 6th, 7th, 8th, 9th, 10th through 12th weeks after their incarceration. The ethnicity on these events was actually switched. It was more white than black, a little bit less, still more male than female, but a little bit less male dominated. Those with a mental health tag did not dominate this group. It seems to be people that are not identified with the serious mental illness at that point. Then we wanted to do an analysis for the detention facility just to sort of show what are the diagnoses that are present? So we want to be able to give the detention facility a broad overview of what is present in your population. So here we're looking specifically, for this part of the analysis, we're looking specifically in that mental health tagging period, 2014 to 2015. Again, we had 6,831 people confined during that tagging period. Of that time period, 1,263 had a diagnosis of schizophrenia, bipolar disorder, or depression based on their Duke health records. And during that period, 134 of them were tagged with that mental health tag at the jail. So here's the breakdown of the full population. So this is everyone who was incarcerated during that 1.5 year period. Just like, you know, in general, 81% of people had no diagnosis. About 2.24% of people had schizophrenia only, and then another 2.5% had schizophrenia and one or both of the other two serious mental illness diagnoses. Same for bipolar, about 2.5%, and then another 4 or 5% had bipolar and something else. About 10% of the population had major depressive disorder, and then another 4% had depression and something else. So this, how does this map on to the typical population outside of the clinic? Outside of the jail, which is that, as we know, the serious mental illnesses are overrepresented in prisons and jails. Schizophrenia is about 1% prevalent in the general population. Major depressive disorder is actually about the same in and out of jail. So that was about 10% in both the jail and the general population. And bipolar disorder is a little bit overrepresented in the jail. So I wanted to share this. This is a great graphic from a systematic review of mental illnesses in state prisons and community samples. It was published in 2014 when our data frame started, looking at each of these specific diagnoses and asking how prevalent they are in prison samples. So each of the black dots here is a different publication. So this was a systematic review, so pulling together multiple publications. Prison data, and then the gray dots are community data for bipolar disorder. And then the red triangles are our data from Durham County Detention Facility. So how does Durham map on to things that are published from around the world? So Durham is pretty well right on in terms of bipolar disorder for prison populations, pretty normal in terms of major depression and schizophrenia, a little bit overrepresented in terms of mental illness. And I think that's a testament to just the data source that we use to more broadly catch these diagnoses. So Durham's pretty normal. And then breaking down the population into those who were seen at Duke Health and had a diagnosis of any serious mental illness from Duke. So among those who do have a serious mental illness, what is represented in that population? Overwhelmingly, major depressive disorder is the most common, which is true in the population as well. Bipolar and schizophrenia are less common, but still quite prevalent. If you look at what was tagged, though, this is the overlap where things were recognized at the detention facility and also recognized at Duke Health. Those that were recognized both places, overwhelmingly more schizophrenia was recognized both places. Bipolar and major depressive disorder were also recognized both places. But the things that were missed at the detention facility, there's a lot more major depression in the population than was caught at the detention facility. And this doesn't reflect any shortcoming on the detention facility, because we know that depression is a cyclical illness. Someone may not be in their depressed state, may not be thinking that they need their medication while they're in jail. And so we just put this out there to say that all of these things are so present in the jail population, and just something that we want the community to be aware of. So then that led us to ask the question, so why are people with mental illness coming back to jail, and why do they keep coming back repeatedly? So this is data from last summer's group of students. We split it, we looked at the tagged over here, non-tagged populations over here on the other side, to see we have the data on what crimes they were charged with upon booking. And turns out that the types of crimes committed are not terribly different between the two groups. The black and the orange are kind of the miscellaneous, not really fitting into a category. The light blue is people who were arrested for missing a court date, missing some kind of procedural expectation. Those are pretty similar across the two. Green is automobile crimes. So you see a much higher percentage of automobile crimes in the non-SMI tag group, partly because our SMI tag group is generally poor, generally homeless, don't have cars. More property crimes in the SMI tag group. That's things like trespassing, breaking and entering, petty theft. So again, here's a group that's homeless, more likely to get arrested for trespassing. So there's a few more property crimes, fewer vehicle crimes in the mental illness group. Violent crimes are pretty similar across the two groups. Drug crimes might even be less in the mental illness tagged group than in the non-tagged group, and sex crimes are pretty rare in both groups. We wanted to dig in a little bit more to this question of drug crime because we read several things in the literature that suggested that the comorbidity, we wanted to unpack comorbidity between mental illness and drug crimes to see if that had anything to do with increasing rearrest. And this is work done by Matthew Ralph in our group. He split them into 4 categories. So the light green is individuals with no relevant diagnosis from Duke. Dark green is those with a severe mental illness only. So that's just schizophrenia, bipolar, and major depression. So if they just had one of those 3, if they had a substance use diagnosis only is the light blue. And if they had co-occurring severe mental illness and substance use, that's the dark blue. And so the y-axis here is the percentage of each of these populations who are rearrested in either year 1, year 2, year 3, or year 4 after their first arrest in 2014. So what you can see is the 2 blue groups, those with substance use or a co-occurring substance use and mental illness, are much more likely to be rearrested across those 4 years than those with either no diagnosis or a mental health diagnosis alone. Over 4 years, about 60% of the whole population gets rearrested from their first arrest. If you give them 4 years later, about 60% are going to be rearrested, but that rises to about 70% if someone has a substance use disorder or a co-occurring disorder. So why are they getting rearrested? We hypothesized that it might be because possession of illegal drugs is a crime in itself, and so someone's mental illness is technically a crime, and we wondered if they were getting more arrests because of drug crimes. And it turns out that that's not exactly the case. I'm sorry, the labels are so small here. But the first column is those with no diagnosis. Second column is mental illness only, substance use only, co-occurring illness only. And the orange here is drug arrests, drug-related arrests, and the green is everything else. So you don't see more drug-related arrests in the 2 groups that have a drug diagnosis, a drug abuse diagnosis. You see a little bit fewer drug-related diagnoses in those with severe mental illness only, but in general, it doesn't look like drug crimes are driving rearrests and are driving either the first arrest, and here's the rearrest. Here again, about 30 to 40% are not rearrested, but among those who are rearrested, drug crimes are not really the dominant cause for arrest. So it's not that they're being arrested just for having a problem that is illegal. So that's not what's going on. So then we wanted to unpack a little bit more about the types of mental illness and whether externalizing versus internalizing disorders were driving those rearrests. It turned out there is some evidence to suggest that the externalizing nature of schizophrenia and bipolar might be related to the rearrest. So their behaviors might be more demonstrative out in the community that leads to rearrest. So drawing a line here, so the bottom line is those with no diagnosis, same data across the board. Green line here is those with only a substance use disorder across the board. And then you can see that those with schizophrenia are more likely to be rearrested than those with no diagnosis. And those with a combination of schizophrenia and a drug abuse, a substance use disorder, are the most likely to get rearrested. Same thing for bipolar. Bipolar alone increases the likelihood of rearrest, increases it even higher above those with substance use alone. So in comorbidity, bipolar disorder is exacerbating. But major depression actually seems to be a mitigating factor. So those with major depression are less likely to get rearrested than those with no diagnosis. And those with a co-occurring major depression and a substance use are a little bit, slightly less likely to get rearrested than those with a substance use disorder alone. So there seems to be some combination between an externalizing disorder and that is exacerbated by drug use that drives this rearrest. So to put it all together, most of the incarcerated people who have been through the Durham County Detention Facility do use Duke Health. We had about a 75% match rate of those who had ever been seen at Duke. Mostly they're coming to the ED. Less frequently, they're coming to the Lincoln Community Clinic. Those who are familiar faces at the detention facility are often also familiar faces in the ED. During that brief tagging period in the jail, SMI tagging did a good job of identifying those externalizing mental health disorders, but often miss major depression, and that makes sense. Rearrest seems to be driven by those externalizing illnesses and also to be exacerbated by drug involvement. And then our future questions are to look at, we're just now beginning a longitudinal analysis to look at how Durham's efforts are affecting this population. So have all these things that we've been trying to do over the past few years, are they really helping, and how is that affecting this population? Is there room for more collaboration? Absolutely, yes. Michelle Easter has just started attending meetings from the frequent attendees ED group. So she's trying to bring together our data with what can we do on the ground to help break this cycle. And of course, I want to thank all the team members that worked with me. So this is the BAS Connections and Data Plus team that is co-led by Maria Tackett and myself. So Maria is an amazing statistician in the Department of Statistical Science here at Duke. Michelle is our collaborator who is in the group with Marvin Schwartz and Jeff Swanson over in the psychiatry department. We've been supported by two great grad students, Becky Tang and Ruth Weigel, who take turns leading the students in their research each year. This year's undergraduates, who are also coming back to join us next year, I'm so excited, are Matthew Ralph, Liz Wynn, and Bella Larson. I showed you work from all three of them. Last year's group was Aiden Fitzsimmons, Brooke Scheinberg, and Joseph Chu, and I showed you a little bit of Aiden's work with the crime types at the beginning. Huge thank you, of course, to our community partners from the Durham County Detention Facility, Major Bazemore, also Sheriff Burkhead, who continues to sign off on our data use agreements, and our other leader, Anthony Prignano at the jail, Gudrun Palmer, who is the director of the Criminal Justice Resource Center, Leylon Williams, the CIT liaison for Alliance Behavioral Health, the whole CIT collaborative, those at the Duke Analytics Center for Excellence who merged our data from the jail with the Duke Health data and completely de-identified it, so we had no chance of knowing who was in that data set. And then the whole BAS and Data Plus infrastructure here at Duke, so thanks to Lynn White and Dana Ripperton, who are the leaders of the Brain and Society theme, and then Paul Bendich and Ariel Dawn, who lead the Data Plus group. So thank you guys for all your help. And I will stop the screen share and be happy to take any questions.
Well, thanks, Nicole. That was just great, putting some numbers to the issues at hand and making it more evident in terms of pathways for how we can make progress. So now we do have some time for questions. I have a question. Were there any numbers in terms of drug abuse, different types of drugs? You mentioned opiates, but just wondering in terms of other stimulants, cannabis, hallucinogens.
Yeah, it's in there. It's a little bit more vague. It's one that's not as well defined in the Duke Health data. So sometimes it will say opiate addiction. Sometimes it will say general drug addiction. So we have not gone down that road just because the data is not as clean.
Other people have questions, comments?
Yeah, I do. Nicole, thank you. That was a wonderful presentation. It was really, really great. I have a couple of comments and a question. First of all, thank you for just doing this kind of work. This is an understudied and extremely important area that I can't emphasize enough how critical it is that we understand more about how mental health issues drive criminal behavior and interface socially with the justice system. I've had some experience, consulting on matters like that, and it is just one of the saddest things to me that our criminal justice system and our mental health systems interact as ineffectively as they do. So this work is to be applauded in that way. I would also say, just because I do happen to know you and your history, this is a great example of how scientists don't have to stay in their silos. Okay, you are an excellent basic scientist, and you're now doing work in the social sciences related to, but outside of your original field of training. And I want to compliment you for that. I think that's the kind of professional and personal flexibility that we should all aspire toward. And now my question.
Okay.
And so you talked a lot about the relationship of having a diagnosis to how people fall into the system and so forth. What about treatment? So are there differences in people who are undergoing treatment? How does treatment interface with this, in other words? And so would somebody who's under pharmacotherapeutic treatment as opposed to psychotherapeutic treatment, for those who can get it, of course, right? But you see my question here, I think. Does treatment change these numbers? And if so, how? And perhaps differentially across the different kinds of disorders that you've been studying?
Yeah, absolutely. I'll call this talk the teaser, and I'll share a little bit of the preliminary data that Maria Tackett, Maria has just started the longitudinal analysis. So that's taken a lot of data cleaning. We're just getting to the longitudinal analysis. Short answer, like the very preliminary thing, is that it looks like the patients that are cycling through the emergency room are more likely to get rearrested. The patients that are cycling through Duke outpatient clinics are a little bit less likely to get rearrested. So I hope that means that, yes, those that are actually getting and engaging and able to engage with treatment are the ones that are less likely. We've also just gotten data we just got approval to start analyzing data from the jail since they started that medically assisted treatment in the jail. And that, as Major Bazemore's nodding his head, so that's a really inclusive effort to start medication-assisted treatment in the jail and match those people to treatment once they are released out into the community. So yeah, you're one of the things you said earlier is that it's so understudied and under collaborated in many communities, but Durham is trying really hard to do a lot of things in the right way. So I want to give a shout out to all these community partners that I see, Leilon and Major Bazemore and Gudrun and many people who Durham is so ardently trying to do the right thing. And it just makes this a joy to do. It's a joy to do this work. But yeah, stay tuned for how does treatment really help? Is it really helping? And that's what we're working on next.
Nicole,
yeah.
I do have one question. I want to start out like Scott. We are so appreciative of the collaboration that you have with Durham. It is just most appreciative because it answers a whole lot of questions, and it helps us in doing our next steps, and we are better able to do what we do in the community as a result of this research. I am barred from talking politics or religion while on duty, but I'm going to ask this question because this is the second report that I've heard. And it just makes me wonder, if we had Medicaid expansion, would that eliminate some of the problems we had? And for this group, the thing that I thought most alarming in this report was not that our mental health individuals were coming to the detention facility, but it was our substance use, people with substance use disorder, their rearrest and their recidivism rates were alarmingly high. But again, I'm just wondering, and especially when I heard that number of the familiar faces report, that really caught me, because I think that's our SPMI population that we are having to deal with.
One of the things that I'm, always starting to look ahead. One of the things that I want to do next is start to talk to actual people who are living through the numbers that we've seen, and just say, what is it that keeps bringing you back, or what would help you to break out of that crisis cycle? The CIT is great because it takes people in crisis to a safe place, but then if they're getting back into a crisis a month later, what's missing? What do we really need? And so that is the next step. You and I can agree on politics in many ways and advocate for Medicaid expansion other places. So I won't put you on the spot for politics.
The question that I had, it was a long, long time ago when I was attached to the federal bench, but we had an awful lot of recidivism associated with alcohol. And I know that that's not the sexy drug these days, but I am assuming that is still one of the drivers for this population. And I know it didn't sound like you were able to separate out the substances within that broad category, but was there any sense that alcohol was a major player, or did you not see it?
The fact that you guys are bringing that up makes it, maybe we should dig into that a little bit more. It was there. It certainly is there. I don't know, but it may be worth doing the extra work to tease that out of our codes, our diagnostic codes.
Well, and it also had it play. It's like opiates. It's a very expensive drug because it often is related to accidents and other issues that have very, very high expense value in terms of human capital, but also in terms of just plain dollars. And so I think, again, I have a particular interest in that, and I think it's important that we not, just because that's quote unquote a legal drug, not let that slip away. But I thought it was like Scott and others, I thought it was a great presentation. And this is a population that is both needy, but the neat thing, and again, if I go back to my experiences attached to the bench, we saw a lot of really positive outcomes if they got appropriate care. Mm-hmm.
Yeah, and it's something that it comes to my mind so many times that there's certainly a need for more money in this area, but working with the crisis intervention team, it's all about just the energy to care. We have people who come to these meetings once a month because they just care, and their paying job is something different, but we show up to these meetings because we care about making the system better for our most vulnerable citizens. So it's a combination of just a little bit of money to help people get paid to do the work and do the right kind of jobs, but as a society caring about our most vulnerable citizens, I think it's a change that is happening, and hopefully will keep going on.
Other questions? Hands? I had a question. In terms of first responders, so if there is an incident that the police respond to, certainly if that incident involves fire, well, you bring in the firefighters, or if it involves some medical injury, then the medics. So is there a movement to, if it's obvious to the officer that it involves some, mental illness, then they could call in a first responder for mental health who is trained to deal with that?
Yeah, my first responder colleagues can correct me if I'm wrong, but there's the short answer is there's a wide variety, and a lot of things are being tried across the country. So in Durham, we have the CIT model, which is that first responders are still the same, but that they are trained to very quickly transition someone who's in a mental health crisis over to the crisis center, and then get back to doing their law enforcement job, but hand off. Other cities are doing things like having a social worker or counselor do ride-alongs with the first responder so that they can come together to the scene and immediately interact with the person in crisis. Still other cities, I just heard a presentation from Eugene, Oregon a few years ago, that when the 911 operator recognizes it as a mental health crisis, they're sending counselors out without a law enforcement officer, so that there's none of that, you know, the stress of seeing the badge and the gun, and sending the social workers and counselors out first. And their model seemed quite successful. There was only about 10% of the time that when the crisis call was properly identified, only about 10% of the time did it escalate to the point that law enforcement was then called in. So yeah, there are a lot of models being tried around the country, and you know, different things are working. Yeah, it just comes back to how our city wants to allocate its funds, and how we want to pay people to care, and pay people to be out in the community.
And
Do you have anything to add, Baze?
Yeah, the other thing I was going to add is, even in Durham, we had a mobile crisis team, but their response time was around the 2-hour mark, and I'm not certain what's going on with mobile crisis. We did a follow-up last year sometime just to see if they were still active. So
yeah, that's not going to be what you need.
No, you need people at the ready. So, the other thing is, in terms of recidivism, so you chart people who are coming back into the being re-arrested, but what happens when they're released? I mean, you would think that that would be an opportunity to have some continuing, it's kind of like aftercare. If somebody's let out of the hospital, then there's a step down unit or some appointments to make sure they're back on the road to recovery. So is that a place where we could have some progress in terms of having a step down, you know, engagement as somebody is released?
Yeah. So that's what the Criminal Justice Resource Center does. That's where probation and parole is managed. Tons of, and Gudrun and Leilon can add to this here. So tons of collaboration with the local reentry council, efforts with job fairs, job placement. The Criminal Justice Resource Center is well connected with counseling services. Leilon and Gudrun, is there anything you would add to that?
well, we have discharge planners in place.
Yeah.
But they are only referred people that are SPMI with an ACT team. So that kind of limits the number of individuals that are actually referred out that's going to actually get assistance when they leave the.
Hi, I'm Gudrun Farmer with the Criminal Justice Resource Center, and Major Bazemore is right. But over the years, I think we've done a good job adding additional services, like we have the mental health court that Nicole mentioned earlier, which can help people that are, while they're still pending their court case. We also have the local reentry council, and so if someone at the detention center lets the individual know about the local reentry council, they can come. They can contact the local reentry council. They be connected to treatment, housing, all the basic needs. And then if they are on correctional supervision, probation, then they can also come to us for services and be talking cognitive behavior, substance use treatment, and again, all the wraparound services that someone would need. And we refer to Alliance for anything that we cannot provide ourselves.
Sure. Thank you.
Yep.
Other questions, comments?
Well, I also just want to chime in. This is Leilon Williams with Alliance Health. I just wanted to chime in with the question that was asked earlier. So with the Durham Police Department, they do have a specific CIT unit. And within that CIT unit, it's a clinician that actually works with them on that team. Clinician now is starting to take live calls and go out with them on certain calls or whatever. But basically what the clinician's responsibility was prior was doing a lot of follow-ups to try to help individuals get connected that have called in probably previously to get, you know, services in a crisis and so forth and so on. But, you know, their primary function was to actually help individuals get linked up to services. And, you know, of course, going to the crisis center, that's one of the main things that we really emphasize within crisis intervention team, because you know, it's one thing to go to the emergency department and get a crisis resolved, but then after that, helping individuals get linked up to ongoing services was where we kind of had a big issue at. But, you know, the Crisis Center does a really good job of helping individuals to get linked to ongoing service.
Okay, thanks.
Thanks.
Andrew Hockey, I had a question. Andrew?
I see Andrew says, I was going to ask another question about alcohol. For recidivism rates, there's the issue that alcohol-involved crimes like DUI are likely to recur, but may or may not fit in the classical definition of alcoholism. Is the labeling framework you have able to tell the difference between these kinds of problematic versus dependent alcohol users? I would say, sort of yes. I mean, the fact that we're merging Duke clinical data where there could be a clinical diagnosis of alcoholism. And my student Matthew popped up a minute ago and said that in our SUD tag from the Duke Health, we have both alcohol and illicit drug use, but not tobacco. So it's all in there lumped together. But yeah, so we could tease apart the clinically defined alcoholism that Duke Health put the label on for, and then we can look at who's arrested for DWIs and put that together because we've merged these two data sets. So yeah, that's, so where would you go from there, Andrew?
Get his answer later.
Okay, that's fine.
That's fine. So in terms of resources, you know, there are resources that are, you know, come from the city or county budget or police department budget or Duke's budget. But there are other maybe less dollar resources, but more in-kind resources of, you know, family and community. And are there efforts in terms of engagement of the community and family church resources in terms of human activities to help have this wrap around after someone has an encounter to, you know, get them back to not being encountering again?
That's, yeah, Gudrun, go ahead.
I'm not certain whether it goes to the heart of your question, but so we have, over the years, we have made an attempt, and I think we've done a good job engaging the larger community, especially the faith community. And for some of our more vulnerable populations, especially people coming out of long-term incarceration, we, the Religious Coalition for Nonviolent Durham and some other faith communities have formed support teams that are staying with our clients sometimes for many years. So the initial intent is for them to support them for a year. While we provide services and they receive treatment and all that, but then they also have this longer term support team after they're done with probation, after they're done with treatment, mandated treatment, for example, and they will carry them forward. And a lot of times they stay connected well beyond any formal relationship agreements. So the faith community spawned, and then through the local reentry council, we have reached out to more non-traditional agencies. So and trying to engage as many agencies that are willing to work with justice-involved individuals, not just city and county funded organizations.
Mm-hmm. Okay, thank you. Okay, any final words? Well, Nicole, this has been great. Both your presentation and this very interesting discussion. And clearly there's a lot of work that's needed, and I really laud you for doing this and playing a leading role in you know, cataloging it, but also, you know, trying to get people together in terms of solutions. So thanks again for your efforts, and look forward to hearing the next chapter in the progress in the coming years.
Well, yeah, thank you, and thanks to my community partners for joining in and filling in the gaps. That I learned a few things today. Some things are even better than I realized. So thanks to this group for hanging with me, and see you soon.
Okay, and we'll see everybody in 2 weeks. We'll have our last seminar in the CABC series from Isaac Lipkus about tobacco smoking in the youth. And then we'll pick up again in August 25th for the fall seminar series.